Hello, good morning. So today we are going to talk about prioritizing activities. This is important to think about when designing electronic health records because fundamentally, many electronic health records were originally designed for billing purposes or for entering data into a database. As we move to supporting real-time care in hospitals, we have to think about what are the most important tasks and how that might impact the data quality of an electronic health record. So the guiding question for this lecture is, how do experienced hospital nurses prioritize and plan their activities during a work shift, as well as make real-time adjustments as unexpected events like a patient bleeding out unfold? So this inspiration for this lecture comes from Pat Ebright, a close colleague, who is a nurse who has a PhD and who got a grant funded to look at this idea of stacking. And so how she defines stacking is prioritizing a list of your to-dos. What are your to-do activities for a work shift? And how do you know when to add to them, such as oversighting more junior physicians or dropping things from the list as you get busy? Because fundamentally, the hospital setting, pretty much everywhere, kind of has too much to do for nurses, at least to do safely. And so a big part of their expertise is knowing when to add and when to drop what is on the plan. So nurses participated in a series of focus groups with us. And one of the strongest quotes was, "When I was a new nurse, I was more stressed. I'm not a bad nurse," and there's a phrase of bad nurse. Certain things don't get done, and it is okay to put some things off because they will not be detrimental to the patient. So over and over again, we heard this idea of bad nurse. And so no nurses want to be a bad nurse. And so there are things that nurses expect of each other that they want to contribute to the nursing community by not dumping a lot of work on the next shift. And at the same time, they need to make sure that patient care is prioritized and that the patient is kept safe during a work shift. So these were the strategies that we identified expert nurses across all settings in the hospital doing. One is to continuously redefine what is most important right now. Another is to manage the workload, such as by saying that something can be put off or something can be done in a future shift. There were proactive investments that were made, things added to the list in order to avoid cascading effects. So if a patient was getting anxious and worried about something, it was worth the time to sit down and explain what was going to happen during the shift, set expectations, set when the nurse could be called for various activities and respond quickly, and when there were likely to be times when there would be delays. Definitely nurses invested in other nurses and physicians and allied health colleagues in order to be able to call on them in the future when they needed help. And then there was a clear distinction between things that were a drop everything event, a patient's heart has stopped, versus things that are the reason why the nurse is there, the reason why the patient is there. So medications are administered, dressings are changed. So there are clear core duties of a nurse. And then there are things that we want to do and we absolutely are going to try to do, but they absolutely can be dropped when things are very busy. And that's probably the most important aspect of this, is knowing what is potentially droppable. So at the top level, the example of the absolute highest priority, the drop everything, is a ventilator disconnect. So if a patient will not be able to breathe until they are put back on a ventilator, that's now the top priority of your shift. Another thing we saw was nurses talking about the first time they use equipment or a patient who they're really worried about because their vital signs are unstable. So anytime there was high uncertainty, that would go pretty high up in terms of priorities, only being after the sort of emergency events. And then again, pretty high up, it's going to happen, were things like assessing the patients. Sometime during that shift, So each and every patient would get a personal assessment from the nurse. That was considered a core duty of nursing. Where sometimes things started to get delayed or dropped was at the level of helping colleagues. So if you're trying to help a physician insert a central line, you definitely want to do that. But there could be times where you might delay it or even potentially get somebody else to do that if you are overwhelmed. With patient education, this is super important for patient safety, particularly after discharge to home. And if you just ask nurses, do you care about patient education? The answer is absolutely. On the other hand, given this task priority hierarchy, given the situations that nurses are sometimes having to deal with, it is not infrequent to, in some way, do education less well, delay it till the next time, give it to somebody else to do. I think this finding is potentially some of the most surprising for electronic health record developers and also hospital administrators, is how low on the list documentation was, particularly things that were required for hospitals to remain accredited by the Joint Commission. So every time a patient is given a pain medication, there has to be a follow-up that says, did their pain on a scale of 0 to 10 go down in response to the medication? And relatively frequently, this would get dropped. There was a definite need to improve supplies. So nurses spend an awful lot of time going around and finding a marker is broken, looking for another one. Oh, it's missing here. Oh, I'm even have to order one. And part of the reason this occurs is because when supplies run out or are broken or are missing, fixing it is so low on the priority list that it can go for a long time before somebody finds enough time to take care of it. And then every nurse had plenty of examples of where they didn't eat lunch, didn't go to the bathroom, stayed late, put their own personal comfort at risk so that they could provide all the things that had to be done on a work shift. So in conclusion, the novice nurses had a feeling of overwhelmed. Some of them talked about waking up in the middle of the night for the whole first year that they were nurses, having almost like a panic reaction to the feeling of what to do when there's too much to do in a shift. Whereas expert nurses had a sense of calm because they had learned stacking strategies. They knew real time what they were supposed to do to that stack, how they were supposed to add, drop, and what actually had to be done every shift. And in particular, crises got taken care of. High uncertainty tasks were done first because you don't know how long they're going to take or what's going to be involved. And then core duties are going to happen in this shift. And then a lot of other things got shed when nurses are busy. And in particular, patient education and documentation would be shed. So if these are truly priorities of an organization, it might be the case that staffing would have to be increased. So more staffing for fewer nurses, fewer patients to nurse, or new roles created, support personnel to help nurses accomplish these activities. Thank you for your attention. Have a good day.